Hey, welcome back. So, today we're putting on our detective hats. We're going to be solving some pretty serious mysteries. But these aren't your typical whodunits. Nope. These are hidden deep inside the body, in the liver and biliary system. And our main tool? Medical imaging. Let's get started. So, picture this. You go in for a routine scan, and they find a spot on your liver. Whoa, that's a moment, right? It's full of questions. But for a radiologist, that's not the end of the story. It's the beginning. For them, it's a puzzle, and trust me, they've got a whole bag of tricks to figure out exactly what's going on. Okay, here's the game plan for today. Think of it as our roadmap. First, we'll look at the radiologist's basic toolkit. Then, we dive into our first big case, decoding liver lesions. We're going to talk about how they flash, fade, and glow when we use contrast dye. After that, we'll open up a whole new case file on the gallbladder, see what happens when things get a little intense, and then we'll wrap it all up with the final report. You know, to solve any mystery, you can't just wing it. You need a system. And radiologists, they definitely don't guess. They have this really methodical way of figuring out if something is harmless, what they call benign, or if it's something more serious, malignant. It's all about gathering the clues and knowing how to read them. And that system, it's really built on three main things. First up is morphology. That's just a fancy word for its shape and edges. Are they smooth? Are they jagged? Next, they look at its tissue characteristics. Basically, what's it made of? Is it just a simple fluid-filled sac, a cyst, or is it something more solid? And then there's the third one, and this one is a real game changer, dynamic vascular enhancement. All that means is they watch how it reacts, how it lights up and fades when they inject a special contrast dye. All right, let's do this. Time to open our first case file, a mystery spot in the liver. Now, the very first tool a radiologist is going to pull out of their bag is usually the ultrasound. This is what gives us our first batch of clues. So, ultrasound is pretty cool. It uses sound waves to create a picture. And on that picture, a simple, harmless cyst, which is really just a little bag of fluid, shows up as anechoic. That just means it's totally black. A benign angioma, on the other hand, often looks hyperechoic, which is a fancy way of saying bright white. But the thing that really gets their attention? Vascularity. If that spot has its own blood supply and its edges look kind of shadowy, well, that's a clue that says, hey, we need to look at this a lot closer. But ultrasound is really just the first chapter of the book. The real story, the one with all the juicy details about what this thing is up to, well, that comes from a CT scan with IV contrast. This multi-phase imaging, this is where the biggest clues are hiding. And that brings us right to the heart of the matter. We're going to watch how different spots react to that dye over a few minutes. We've got three main suspects we're going to look at, and each one has its own totally unique signature, its own way of flashing, fading, and glowing. Okay, suspect number one is something called focal nodular hyperplasia, or FNH for short. And good news, this one is benign, it's harmless. So before we add any contrast, it looks hypodense, a little darker than the liver around it. But then, bam, in the arterial phase, right after the dye hits, it lights up super bright and evenly. And then almost as fast, in the later phases, it becomes isodense. It just blends right back in, like it was never there. A great analogy for this is a restaurant at night. The lights flick on, really bright and fast, but then they just stay on, steady, blending in with the rest of the city lights. It's a very predictable, totally non-threatening pattern. All right, on to suspect number two, hepatocellular carcinoma, or HCC. This is a primary liver cancer. Now, it starts off looking kind of similar, a little dark on the first scan, and just like FNH, it lights up really bright and fast in that arterial phase. But, and this is the critical difference, in the later phases, it does something called a rapid washout. It doesn't bend in. Nope. It gets dark again fast, even darker than the liver tissue around it. And the analogy for this one, it's perfect. Think of a flashy billboard on the highway. It lights up, boom, super intense, grabs all your attention. But then, it just shuts right off, leaving darkness. That big flash, that's the arterial hyperenhancement. And that sudden shut-off, that's the signature move, rapid washout. So what about our third suspect, metastases? These are cancers that started somewhere else and spread to the liver. How do we tell them apart from HCC? Well, they can both light up in that first phase, but they do it differently. Metastases often have what we call peripheral enhancement. They kind of light up around the edges like a rim. But here is the absolute number one key difference. Metastases do not have that rapid central washout. The tumor holds onto the dye. So not seeing that billboard shutting off is a huge clue that we're looking at something different. And then we bring in the MRI, which is amazing for looking at soft tissues. And what do we see? It confirms everything. The pattern for HCC on an MRI is the exact same story. It lights up bright in the arterial phase and then, whoosh, rapid washout. Getting that same signal from both CT and MRI, that makes the diagnosis pretty much a sure thing. That 1-2 punch is the definitive signature. Okay, let's close the book on that liver case for a minute and move on to our second investigation of the day, the gallbladder. Don't let its size fool you. This little organ can cause some major trouble. And you guessed it, imaging is how we figure out what's going on. Now, when we're talking about the gallbladder, there is one clear champion for the first look, and that's ultrasound, hands down. It's the go-to because it's safe, it's cheap, and it's happening in real time. CT scans, surprisingly, are actually not great for finding gallstones, and the reason is kind of interesting. Some stones are just so similar in density to the bile around them that on a CT, they can basically become invisible. Poof, gone. So what are the telltale signs on an ultrasound? Well, you're looking for these little round, bright white spots. The technical term is echogenic foci. But the most important thing, the absolute gold standard, is something called posterior acoustic shadowing. It's this clean, black shadow that trails behind the bright spot. That shadow is proof positive that you're looking at a hard object blocking the sound waves. And if you see the little stones moving around when the patient shifts, well, that pretty much seals the deal. Case closed. But just having gallstones isn't always the main event. The real trouble starts when one of those stones gets stuck. And that's when you go from just having some pain or colic to a real medical crisis called acute cholecystitis. That's a fancy term for a seriously inflamed gallbladder. And this is where ultrasound's real-time ability becomes like a diagnostic superpower. There's something called the sonographic Murphy sign, and it's a dead giveaway for acute cholecystitis. Here's how it works. The person doing the scan gently presses the probe right over the gallbladder, and if the patient feels a sharp, very specific pain right there, that's it. You can't do this with a CT or MRI. It's a unique and incredibly powerful thing you can only do with ultrasound. Now, if that inflammation goes untreated, things can get really, really serious. It can lead to a life-threatening condition called gangrenous cholecystitis. There are a few warning signs we can see on the scans, but I want you to focus on one in particular: intramural gas. If you see little bubbles of gas inside the actual wall of the gallbladder, that is a massive, critical red flag. It means the situation is severe, the mortality rate is high, and that patient needs to get to surgery, like, right now. Whew. So, after all of that detective work, the scans, the contrast dye, the poking and prodding in real time, it's finally time to file the report. So let's boil everything we've talked about down to the absolute most important takeaways. So here it is, your diagnostic cheat sheet. When you're thinking liver, that washout pattern on CT or MRI is the huge clue for HCC. When you think gallbladder, just remember ultrasound is king. For gallstones, you've got to look for that posterior acoustic shadow. For acute cholecystitis, that sonographic Murphy sign is what clinches the diagnosis. And for a true emergency, gas in the gallbladder wall is the 5-alarm fire you absolutely cannot miss. And just like that, our investigation is closed. We've seen how radiologists use these amazing imaging tools to figure out the what, to identify a problem with unbelievable precision. But that just leads to the next big question, right? If imaging tells us what the problem is, how do we decide what to do next? But that's a whole other story.